this lesson, and I understand that we are doing health assessment. So it's just a continuation from where we ended doing an assessment of this patient. So today we'll focus I want us to focus on the cardiovascular assessment. Okay. I understand that you have done human anatomy before, and before we get into this section of us assessing the cardiovascular system, we needed to also maybe do a review of human anatomy. The review is just the surface anatomy, not too detailed, but at least as a nurse who's training to save lives, you should understand the system which you're dealing with. In this case, which is the cardiovascular system. So we're going to start the review. Anyone who can tell me anything or the components of the cardiovascular system? Yes?
The cardiovascular system is made up of the heart, blood, and blood vessels.
Very good. The cardiovascular system, you're talking about cardio, heart, vascular, blood vessels, right? Mm-hmm. So this is the system we're going to focus on. We're going to focus on the heart and the blood vessels in this assessment. So why is it important for us as nurses or lifesavers to assess the cardiovascular system? Anybody who can tell me the importance of this assessment? I want the class to be very interactive, so feel free to participate, right? I don't know your names yet, but I would love you to participate. Just raise your hand and give us the answer. Why is it important? Okay, so you understand to say cardiovascular diseases, they are one of the leading causes of what? Mortalities. Like which disease? Hypertension, right? Mm-hmm. Yes. So any detection of these abnormalities or pathologies, it is very important because you're going to prevent some of the complications that they come with. Do you understand?
Yes.
Yes. So when you do an assessment, actually, when a patient comes to your facility, you're going to do an assessment first. If you miss out some things during assessment, you're putting that patient on what? Risk. Because during assessment, you can detect potential health problems and also actual health what? Problems. So if it's a potential health problem, you're going to do what? To prevent it. You bring in interventions that are going to prevent the occurrence of that problem. If it's an actual problem, you're going to bring in interventions that are going to do what? To attend to that problem. Are you getting me? Yes. So this component is very important to do. What are some of the cardiovascular diseases apart from hypertension? What else is the disease of the cardiovascular system? Any other disease of the cardiovascular system? Yes.
Cardiac arrest.
Cardiac arrest. What is happening in cardiac arrest? The heart stops doing what? Pumping blood. When somebody collapses, right? Your cells sometimes no pulse. Okay? Any other disease of the cardiovascular system? Any other disease of the cardiovascular system? I can see that we are thinking, right? But let's be quick. Mentioned about cardiac arrest, hypertension, there's also what is known as congestive heart failure, CCF. There's also what is known as cardiomyopathy. I know as you advance in your medicine, you're going to cover some of these what? Conditions. Okay. So it's important when you do an assessment, all those diseases, you can early detect them, and some of them prevent the occurrence of such kind of anomalies. Right. So a quick review of human anatomy and physiology, adding up to what you just said, you find that the heart always, it is located in the medial what? Medial sternum. Okay? Medial sternum at the back of the what? The ribs, right? Or at the back of the sternum. That's where it lies there. Okay? So now, if we are to remove this, and also that you can appreciate how the heart is, the situation, where the heart is situated here. Okay? You can see that it's on the center between the two what? Between the two lungs, but it's projecting much to the what? To the left side. That's why we always say that the heart is on the what? On the left side, because it's pointing to the what? Left side. This is the apex of the heart, and this one is the base of the heart, right?
Yes.
We understand that the heart also has valves, right?
Yes.
The tricuspid, the mitral valves. Apart from that, we have also aortic and the pulmonic valves. So it's important to know all those. So much of the mitral valves, they are located much coming to the apex of the heart. Then the aortic and the pulmonic valves, they are more on the what? On the base. This is important because even during assessment, as you use a stethoscope, putting in those boundaries, then you are going to get a specific heart sound. S1 and what? S2. S2, it is best here on the base of the what? The heart. And S1, it's loudest where? On the apex of the what? The heart. Are you getting me? Yes. So as you listen to these sounds, you need to know the normal heart sounds and the abnormal heart sounds. Okay. So any questions so far? Any question, anybody with a question or a contribution? Okay, so if there's no contribution, no question, we can now get into the procedure. We're going to demonstrate hands-on, because it's of course a matter of theory and the hands what? Hands-on. Okay, so where is So when doing health assessment or when assessing the cardiovascular system, what you're going to need, the tools you're going to need, it is the stethoscope. Okay? This one will help you to listen to some of the heart sounds and also other things here as you assess this particular patient. Okay? So in our assessment of this patient, we're going to use the 4 techniques that are very important in health assessment. Now on that one we need to talk. What are the 4 techniques that are important to health assessment? The 4 techniques? Yes?
Inspection.
Inspection, very good.
Palpation.
Palpation, very good.
Percussion.
Percussion, good.
Auscultation.
Auscultation. So under inspection, what sense do you use? I want a new hand, yes. The sense of what? Sight. Under palpation, what sense do you use? A new hand.
Touch.
The sense of touch. Percussion. Percussion. Yes? Sense of hearing. And the under auscultation. Yes.
Stethoscope.
Use a stethoscope, but you are interested much to listening. Huh? You listen as well to those sounds. Yes. So now, when assessing this patient, we'll move in that what? Order. Focusing on inspection. From inspection, we're going to come to what? We're going to come to palpation. Palpation, we're going to do percussion. But now, on percussion, may I make it clear, it is rarely done this time around, especially when it comes to cardiovascular assessment. Why? Because it is not that much reliable. Because of the location of the what? The heart. You see that it is almost covered by what? The lungs. So even when you percuss the borders of this lung, the heart, you may also, it may be affected by the what? The lungs. Yes, so the part for percussion, mostly it is covered by scans, okay? Machines are going to do that part. Yes. All right, then the next part, the auscultation, we're going to do it using this one. Okay, so we're going to have our patient in form of a dummy in this bed. Okay, so let's have this. Let me just pull this one a little bit so that it is closer here. And you don't need these jewelries as you do these procedures. So have our patient, what name can we give to the patient? Jacob. Okay, so our patient, the name is what? Jacob. Yes. So we're going to wash our hands. Wash our hands with this alcohol hand rub. Then we walk to the patient's what? Bedside. Now, in most cases, as you come to the patient's bedside, you must have what? You can have gloves, especially if the patient is debilitated. You are not so sure about the patient you're about to assess. So carry with you gloves. So in this case, much of these patients you assess during assessment of these systems, you find that they are active patients. Okay? Yes. So when you come to this patient's bedside, you introduce yourself. So you greet the patient. Good morning, Mr. Jacob. I am Mukwali, a student nurse from Rusango University, and I have come to do cardiovascular assessment on you. I'll do this procedure whilst you're in this bed here, and I'm also going to be touching you at some point. Okay? And also I'll be using this instrument to just try to listen and detect if there are any abnormalities. Is it okay with you? Do you have any question? Then the patient, if they have a question, they're going to do what? To answer. To ask. Once you tell them, do you have any question? They're going to ask. Then when you tell them, is it okay with you? You are trying to get what? Consent. They'll tell you, it is well, or it is okay with me. Are you getting me? Mm-hmm. Yes. So is it okay with you? Mr. Jacob has consented. It is well. Okay, thank you so much for allowing us to do this procedure. May I just, then you can come. If you need to prepare anything, you prepare. So since you did an assessment, you wash your hands for the second time. Then walk to the patient's bedside with your stethoscope. Okay? So this patient, first thing, it's a positioning. Are you getting me? It is what? Positioning. So which position are they going to be? In this same position, but elevate the bed a little bit at an angle of 45 degrees. Okay? So may I have somebody to assist me positioning this patient? Let's just come over. So what we're going to do, we need to use that.
So you can get the backrest.
Backrest. That one there. So just going to put this backrest behind here and we put the bed at 45 degrees. That one will help us to So I'll hold the patient, I'll support the patient as she is putting the backrest. So Mr. Jacob will be done very soon. We're just trying to position you. Put it under the mattress.
Under the mattress?
Yes.
Can you put it under the mattress?
If you put it like this, the patient will help the patient.
Yes. Right, so we're going to position the patient in this position. It's okay. So we're going to, this is our 45 degrees angle in this position. This is also known as semi-what? Semi-folders position. Okay, so you put them in semi-folders position. So at this point in time, since I've already gotten permission, I'll proceed with the procedure. Bearing in mind our first inspection, technique, our assessment technique, which is inspection. So Mr. Jacob, I am back, and I'm going to stripe you so that we expose your chest. This will allow us to assess you very well. So you stripe the patient. Just our dam is, so our patient is going to be in this position. But don't overexpose the patient. Just expose the area you are interested to do what? To examine. So in this case, it's the chest. Then I'll start with inspection. So as I stand here, I'll start the inspection, as you mentioned, using the sense of what? Sight. So I'll check how the patient is breathing, the raise and fall of the chest. I also inspect if there are any scars on the chest here, okay? That may indicate any cardiac surgeries or chest surgeries, okay? Apart from that, what am I also going to inspect? I'm going to inspect the symmetry of this chest, okay? The alignment of the chest, okay? And also, I'm going to inspect from here, I'm going to inspect the eyes. On the eyes, I'll pay attention to the issues of pallor. You've heard about pallor before?
Yes.
Yes. Pallor, which may indicate a deficiency of blood supply or low levels, or in short, anemia, right? Yes. Pallor, what else on the eyes? An abnormal discharge, right? Yes, abnormal discharge on the eyes, and also jaundice. I'll assess for that. From that, I'll come from the eyes, I'll come to the mouth, I'll assess how dry, how hydrated the lips are, to rule out issues of what? Issues of hydration. You know that when you're dehydrated, the lips, they tend to turn white and also be what? They develop plaques, cheilitis, right? Yes. So I'll tell the patient to open a little bit their mouth and try to assess the time. Now on the time, I'm assessing the color of the time to rule out cyanosis. You know cyanosis? Yes. Bluish discoloration of the skin. What does it denote? When you find that it is on the tongue, it is a central cyanosis. What do we mean? Central cyanosis meaning the whole body is poorly saturated with oxygen. Okay? Yes. From there, we come to the neck. Now, this neck assessment in cardiovascular, it's very, very specific. Why? Because in the neck there are veins. Okay? In the neck there are veins. These veins and arteries. Okay? But we're going to pay attention more to the veins for now. This blue vein is known as what? Jugular vein. Okay? Draining blood from the head. So pay attention to the distension of any jugular what? Vein. If the jugular vein is distended, why is it significant as a health care provider? Why? What's the significance of distended? You find that this patient has a distended jugular vein. It may indicate left heart what? Failure. Or congestive heart failure of the what? Right side. Are you getting me? Yes. Right-sided heart failure. There will be jugular vein distension. Then on an assessment, we're going to move again as to assess this patient. We're going to inspect now these upper limbs. On the upper limbs, we're going to pay attention. We're going to tell the patient to do like this, okay? When they do like this, you assess specifically the nails, okay? What about the nails? You can detect the cyanosis from the nails, bluish discoloration, which may denote poor blood what? Oxygen supply. That's just the inspection. On here, also you can tell the patient to do like this. When the patient does like this, pay attention to issues of maybe tar staining. Tar staining, it may give you a clue that the patient smokes. And smoking is related to cardiovascular diseases. So when they do like pay attention to staining of the patient, then it do also assess for blood supply. Here, if you find that there is white discoloration, it can also denote what? Pallor. Are you getting me?
Yes.
Yes, pallor, meaning this patient may be anemic. Why? Because the heart is not ejecting enough blood. There is reduced cardiac output, resulting into reduced blood in the circulation. Hence, whitish discoloration, which is the pallor there. Okay, so we have so far at least used the what? The inspection and the things you're supposed to inspect. Inspection technique is gone. Next, we move to where? Palpation. Yes. So let's palpate. Where are we going to palpate? We can come here and palpate in the neck again. Why in the neck? Why are we palpating in the neck? There is a vein and a what? An artery. Are you seeing this artery?
Yes.
This is known as what? Carotid artery. This is a carotid artery. So you can feel actually the pulse from the carotid artery. And that's why you're going to come here, palpate for carotid pulse. Then you feel the pulsation, not the volume. Is it full and bound? And the what? The rhythm. Are you getting me? Yes, and the rhythm. How is the rhythm? And also from this side, you can also come the other side, palpate for the carotid what? Artery. But don't do both palpations at the same time. Why? Because these arteries, they actually take blood to the vital organ. Once you compress them at the same time, you may end up compromising the manner blood flows to the brain. And the brain loves oxygen. It thrives on oxygen. Once there's compromise, the cells, they can easily do what? Die. Yes. So we have palpated. Where else do we need to palpate? You can palpate here on the chest. You are trying to feel for what? Any thrills, any murmurs from there. Okay? You palpate from there. And also, where else can you palpate? You can palpate here. Here you are interested in the what? Radial pulse, okay? From the radial artery. So you palpate also this one, and you feel also the rhythm, the volume, the consistency. Is it full and bound? Is it feeble and weak? And so forth. You can even do it the other side. If you want to go, you can also come here on this joint here, antecubital fossa, this fossa here, palpate. What artery is found here? On the antecubital fossa. What artery is found here? Brachial what? Artery. So you palpate for brachial artery. It's one of the arteries you pay attention to when taking what? BP, blood pressure, right? Yes. You learn that as you do vital signs. Okay. So from here, we have done palpation. What else do we need to do? I mentioned percussion, but I said we're not going to do the percussion. Percussion this time mostly it's done by what? Machines, because it's not as that accurate. Yes. So we're going to go direct to auscultation. Auscultation, yes. So auscultation, we use the stethoscope. We're going to use this instrument. Now, this instrument, mostly, you're going to find those that have it is the anatomy of this one. Are you seeing how it is designed? Some, they are double. They have a bell and a what? Diaphragm. But this one has only what? A diaphragm. Diaphragm, there's a reason. Who can tell me the reason why it has two? Why does it have bell and diaphragm? Bell, it is for low-pitched what? Sounds. If you are listening to sounds that you feel that they are low pitched, then the bell will be able to easily do what? Detect them. But for high pitched sound like the heart sounds, mostly the diaphragm will do what? Can easily, it's for high pitched sounds, the diaphragm. Is it clear? Right, so at least you understand on the stethoscope. So we'll come and do auscultation. Under auscultation, our interest is to listen to the heart sounds. How many heart sounds are there? Two, mainly two, but they can also go up to 4, right? 3, 4, of course, those due to anomalies, but the normal ones, they are 2. S1 and S2. Sound number 1, sound number 2. Okay. So sound number 1, I tell you just here, sound number 1 is caused by closure of which valves? Because we know that these heart sounds are produced by closure of what? Valves, right? When they close like that. That's how also sounds are produced. Are you getting me? Yes. So sound number 1, which valves closes in the heart to produce this sound number 1, which is the lung. Yes. Atrioventricular valves, very good. Which can also, we have mitrio and what? Tricuspid. Okay, so they'll produce S1. Then we also have sound number 2. Now, which one closes to produce sound number 2, which is the dump? Lab dump. Which one? Okay, yes? Pulmonic and aortic valves. Very good. They will produce the what? The dump. Signaling the beginning of diastole. Diastole meaning the heart is doing what? Relaxing. And when the heart is relaxing, it is filling in what? Blood. For S1, it signals beginning of systole. Systole meaning the heart is what? Empty. Ejecting blood to the circulation. Boom. And which one is loudest? S1. Why? Because the heart usually pumps blood at the greater force to eject it so that it can reach the brain, it can also reach down there, your foot, right? Yes, so it will at a greater pace. So S1 usually is loudest. Okay, so having said that, let's start now. I wanted you to understand that importance of those. So I'm going to come here. During assessment, there are landmarks that you need to know. During auscultation, landmarks. So what are these landmarks? These landmarks, they can be abbreviated by these acronyms. Let me give you these acronyms first. Number 1, all patients effectively take medicine. All patients effectively take medicine. That one is a good acronym because it's more related to your field, right? You can't even forget. All patients that are effectively taking the medicine. Number 2 acronym you can use, it is ape to man. From ape to man, but just to say ape to man. Then it will be easy for you to remember these landmarks. Ape to man. Yes. So let's start. The first. Sorry. The spelling for ape. So now,
Give yourself.
Alright, so I hope that everyone is okay with the spelling. No.
This is the
Okay, we have a board here. Man. And the other one is see, all patients effectively take medicine. Okay? So you see how we're going to, each word is going to represent a specific landmark here. Okay? So let me explain the landmark, maybe using this one now for you to appreciate. Okay? We're going to use this visual aid. Now, the first landmark, it is the steno notch. This one here. This one is steno what? Notch. It's a notch. Even if you touch yourself or you look at your friend, you will see it looks like a notch. It is a depression kind of. So steno notch. Then when you come, if you put your finger there, you come like that. Are you seeing this hump here? Yes. You feel something like a hump. Hump. This is known as angle of Louise. Okay? Angle of Louise. Okay. Angle of Louise. This one here. Or if you don't want to call it angle of Louise, you can simply say sternolaminurium joint. Sternolaminurium joint. Steno coming from the sternum, right? Manubrium is the head of the sternum. Are you getting me?
Yes, sir.
Yes, which is here. So when if you come closer, you check here, you find that there is a joint that joins the sternum and its head. That's why you can call it sternolaminurium joint. That one is even easy because once you see the joint, you know to say this is the sternum, this is the sternum, this is the head. And the head of the sternum is known as manubrium. So sternolaminurium joint, which is this one here. Then once you pass the sternolaminurium joint or the angle of Louis, you come to the left intercostal space. Okay? Left intercostal space within the sternal borders. Is it clear? Yes, so as you write, also pay attention so that you don't have difficulties when you go through. Angle of Louis, then left side, second intercostal space within the borders of the sternum. You are going to find what is known as aortic what? Area, not ape, no. You find the aortic area. Okay? Aortic area here. Meaning this is one of the points you're going to put your what? Your stethoscope. And once you put there, you are listening to the aortic what? Area. The sounds from the aortic area. Now, the other landmark, using the same landmark, you just move to the right side. In the second intercostal space, sternal border, you're going to be listening to the pulmonic what? Area. Yes, you're going to be listening to the pulmonic area. Pulmonic area. From the pulmonary. You told me about aortic valves, pulmonic valves, so we also have pulmonic area. Then from there, now, we're going to move left side. If we are to move left side within the sternal border, this is the second intercostal space. We go to the third intercostal space, we're going to be on Ebb's point. Okay? This E stands for Ebb's point. Ebb's point. Okay? Ebb's point. In the third intercostal space within the sternal border. Then from there you go to the fourth intercostal space, which is this space here. In the fourth intercostal space, you're going to be in the what? In the tracheospid area. Okay? So I wrote it in small letters. So tracheospid area, fourth intercostal space. And finally, you're going to come to the mitral area. Now, mitral area is the area of maximum what? Impulse. Are you getting me? Mm-hmm. It's area of maximum what? Impulse. Mitral area. That's where you tap for apical what? Apical pulse. Have you heard about apical pulse? Yes, from the mitral area. Now, this one, it has special landmark. I want you to pay attention. How do you listen to the mitral area? You don't move the way we are moving using this. We are going to come back to the what? Sternum. Or back to the clavicle. Are you seeing this one? Clavicle bone, the S-shaped bone, clavicle bone. So we come on the middle. of the clavicle. Then we start counting the intercostal what? Spaces. 1, 2, 3, 4, 5. On the fifth intercostal space, that's where you can listen for mitral area. It's the area of maximal impulse. Okay. I hope that is clear. So the landmark for mitral area is mid-clavicular line, fifth intercostal space. Mid-clavicular line. Why mid? You are coming. You get the clavicle here. Then you see where it is on the middle. Estimate the mid of the clavicle. Then start drawing a line. But after you draw a line, start counting these spaces: 1, 2, 3, 4, 5, which is the fifth intercostal space. Then you put your stethoscope there. So on auscultating this patient, those are the areas we are going to focus using this what? Stethoscope. It's not just a matter of to say, okay, I'm going to put it here, from there, I put it there, from there, I put it there, and just like that. No, you use those landmarks. So let's see, get started. So I'm going to put here, you come, sternal notch, angle of Lewis, second intercostal space, within the sternal border, you put your what? The diaphragm of the stethoscope. Listen to the which one are you going to be listening to here? Dap, not so. Lambda, because it's on the aortic region. Listen to the dap, okay? Then also, after doing this, using the same landmark, you come to the left, to the right side now. Okay? You start from left side and you come to the right side. You listen to the pulmonic what? Area. What are you listening to? You're trying to listen to the normal heart sound and also be able to detect if there are any abnormalities. If a patient has heart failure or they are having steno valvular stenosis, you'll be able to get even some abnormal gallops or some abnormal sounds within here because of the backflow of the what? The blood in the chambers, right? Yes, you'll be able to get the abnormalities on how this blood is flowing. Then from there, on the left side, you go on the third intercostal space. You're interested in what? Ebbs, what? Point. You listen to any murmurs, any irregularities of the heart or the sounds there. Then you go to the fourth intercostal space, which is the tricuspid. You pay attention also to the murmurs, and also you come to mid-clavicular line. Mid-clavicular line. 1, 2, 3, 4, 5. You come here. You put and listen to the apical pulse or area of maximal impulse. You're going to listen from there and get those sounds. But when listening, mostly sometimes, as you listen, you can also try to palpate the what? The carotid pulse. Especially where you want to differentiate S1 and S2. Because these sometimes they can be very difficult to differentiate. But if you want to differentiate, as you are tapping, also feel for the what? For the pulse, carotid pulse. How are you going to differentiate to say this is S1? S1 always matches, mostly under normal circumstances, it matches with carotid what? Pulse. The one that follows, it is S2. So S1 is loudest here, S2 is loudest here. Why? Because this is the apex of the heart, that's where ventricles are. Here, this is the what? Base of the heart, where the atriums are located, right? Mm-hmm. Yes. So that's how you're going to assess, do your cardiovascular assessment. Okay. So at this point, you can leave your patient comfortably. Leave your patient comfortably, like this, and thank them. Thank you so much, Mr. X, for allowing us to do this, Mr. Jacob, for allowing us to do this procedure on you. Okay? We didn't find any abnormalities. I think much of the things we found are normal concerning your heart or your cardiovascular system. Okay, so thank you so much. Do you have any question or anything that we can help you with here? Okay, nothing, thank you. So you come here and you wash your hands. After washing hands, you need to document your what? Your work. Because work not documented is equals to 0 or work not done. Then you being a student, you report to who? To your fellow student, right? You report to your fellow student. Whom are you reporting to? What? In charge. But you're doing as if you don't know. What in charge? So you go to what in charge. End of the procedure. Any question? So this one, it is very detailed. It can be detailed, very detailed, but we have done what we are supposed to learn at our what? At our level. Yes. Any question or any contribution from the class? Yes?
I wanted to ask where you found the material space from the and you couldn't see the side.
The what?
The material space in the tricuspid area from the you couldn't see the side you're facing.
The materials.
Like those parts.
The material.
Yeah, in the tricuspid area.
So material, anyone who understood on the material, in the tricuspid, anyone who understood what I taught, or what I said, yes, come and show the others using this one. So she is going to show us.
Just forgive me if I... So what I understood about the medial area is you come to the middle of the clavicle, right? Then you count the fifth.
This one they are not seeing it. So say this side. They're going to see it first.
So on the medial, you come on the middle of the clavicle. This is the clavicle, right? Then you count from there until you reach the 50 intercostal, right? On the middle, that's where you...
Just count for them.
Alright, so this is our first rib, right?
Spaces.
This finger. So say 1, 2, 3, 4, 5. But you're on the middle.
Yes, thank you so much. But you don't count the lips, you count these what? Spaces. 1, 2, 3, 4. First 3, 1, 2, 3, 4, 5. Yes. Okay, the spaces. Then that's where you're going to put your stethoscope. Then for what else?
Tricuspid area.
So tricuspid, it's here. Using within the sternal borders. Okay, 1, 2, 3. 1, 2, 3, 4. The fourth intercostal what? Fourth intercostal space is for tricuspid. But put the stethoscope not far away from these borders. Within the sternal what? Borders. Yes, the sternal borders, not somewhere very far or distant. Anything else? Anything else? So we have come to the end of our procedure. Thank you for your attention and also participation. Let's ensure that we practice on assessing this one, assessing how to assess the cardiovascular system. I know it may be difficult with issues of knowing the normal signs. You can use, maybe videos will be shared, right? So that you listen to how normal sounds and abnormal sounds.